Right. So with that, allow me to welcome everybody to today's Africa Cancer Research and Control Echo. It's my pleasure to be here with you. My name is Mishka Sira. I'm a contractor with the Frederick National Laboratory for Cancer Research with support to the National Cancer Institute Center for Global Health. Our Africa Cancer Research and Control Steering Committee Chair, Annette Nakaganda, is handling a personal matter today. So I am stepping in to help facilitate today's session. The topic for today is, or the title for today's session is COVID-19 and Cancer Care in Countries Where There is No Cancer Treatment Capacity. As some of you who have been participating in our Cancer Research and Control Echo in the Africa region know, we have been covering the COVID-19 pandemic and the impact on cancer research and control in the Africa region since early April. And today's session actually comes out of a survey that was conducted, a brief survey that was conducted to look for additional session topics that people wanted to see. And Dr. Jonas from Burundi was very interested in addressing this topic, and we're hoping that he is able to join in as he will be our case presenter because Burundi is exactly that situation where there is the burden of disease, however, the impact of not only the pandemic, but just in general, access to treatment. So Ophira Ginsburg had asked, and I appreciate the question, was to give a brief overview of this COVID-19 and cancer series. So the African Cancer Research and Control Steering Committee had decided to hold a one-off session in April that convened several global and regional cancer experts to address the pandemic. And the session received such positive feedback that the steering committee decided to launch a weekly session for the month of May, as most of us were all in a lockdown situation as it was, to look at various aspects of the impact of COVID on cancer care, cancer prevention, cancer control, cancer research in Africa. And then after May, that's when we conducted the survey, and we decided to continue through at least the end of August, but honestly, I think that this is just going to be the topic of the main focus moving forward indefinitely, to look now more at biweekly and then eventually go back to monthly sessions that will address various aspects as raised by this community in terms of what you all want to see and address as a community. So today's topic is on treatment in or addressing how to address treatment in a capacity where there's no capacity. At the end of the month, there will be a session on cancer surveillance and the impact of the pandemic on cancer surveillance. I actually have a request to the community. We are looking for the August 6th session, supposed to look at country strategies for reopening cancer care services amidst the ongoing pandemic. We are seeking both a didactic and a case presenter for that session. So a didactic presenter is somebody who can give sort of the broad overview perspective. A case presenter is somebody who at the country level is facing this exact issue and wants to share where their country is currently and address some specific questions. So welcome to share by email to me, to Christine, if you want to wave your hand, to others, or just to the whole mailing list, any ideas you might have for a speaker for that session. And then at the end of August, the session will focus on the impact of COVID-19 on cancer research. And we're actually hoping to hear from the International Cancer Research Partnership, who is currently conducting a survey along those lines. Excuse me. Speaking of surveys, I'm sure many of you have been asked to fill out several surveys related to COVID-19. I'm actually going to ask you if you have received, and could you please fill out the survey that's actually related to this ECHO. The steering committee is conducting a survey of the 2019-2020 Africa Cancer Research and Control ECHO, and this will help guide future from August or September 2020 through 2021, the content, the speakers, the makeup of the steering committee, all of that. So it's not a very difficult survey to conduct. If you have not received one or the link to it, please email me, and Christine has been sending out reminders. Thank you, Christine. And So please respond to Christine. So with that long introduction, I will now go into our session. So as I said, what we're talking about today is COVID-19 and cancer care in countries where there's no cancer treatment capacity. We are awaiting Dr. Jonas from the Ministry of Health in Burundi. I believe he has not joined yet, but if I'm mistaken, please correct me. In the meantime, we're also joined today by Professor Frederick Chitayasirwa from the International Cancer Institute in Eldoret, Kenya, and he is going to lead us through the didactic presentation. So a brief introduction or bio for Prof. Chite, who might not need much introduction at all. He's an internal medicine physician and a medical oncologist and hematologist. He's the director of the International Cancer Institute, as I mentioned, and their activities and programs with various strategic partners in more than 16 counties in Kenya and several countries in the sub-Saharan Africa. He's also the program director and PI of Blueprint for Innovative Access Program, which brings various implementing partners together to work on comprehensive cancer control across the patient's journey from advocacy, screening, early detection, optimal diagnostics, optimal therapies, research, survivorship, and palliative care. He was previously the director of the academic model providing access to healthcare, known as AMPATH, oncology and hematology programs from 2011 to July 2019. So as you can see, based on his bio, he is actually the perfect person to be giving our didactic presentation today. So with that, it's over to you, Prof. Chite.
Thank you so much, Mishka. Let me share my screen. Let's see. Can you see my screen?
Yes, perfect.
Okay, so thank you so much for this invitation to this ECHO meeting, the Research and Control ECHO program. Today's discussion is on COVID-19 and cancer care in countries where there is no cancer treatment capacity. So I actually happen to know a little bit about Burundi, and I've been there severally. We've also worked very closely with Jonas, who is, I don't know whether he's joined, but he's going to be doing the presentation for the case.
Yes, sorry to interrupt, but yes, he's just joined now, so welcome, Jonas.
Oh, if he's joined, I could actually defer to him first, then, if that's okay. What would you rather?
Apologies, muted there. Jonas, welcome. Are you able to hear us? Jonas, you're muted if you are trying to speak. Okay, he might still be getting settled, so I don't know if you want to just go ahead, Prof.
Should I just go ahead?
Yes.
Okay. Sounds good. Sorry about that. Most importantly, that even before the COVID-19, I put this presentation to start talking about how do you actually just look at how do you improve and give cancer care in countries where there's no cancer treatment capacity. And then after that, we can actually add the complexity that is added on by COVID-19. So these are some of the major challenges that we've noted in most of the countries, or even counties in various countries, or regions that do not have cancer treatment capacity. And the challenges revolve around infrastructural challenges to support the cancer care in those institutions. They surround around human capacity for cancer care, that even if they have some very well-trained people in various capacities, but the entire team of multidisciplinary team that is needed for optimal cancer therapies is either lacking or inadequate. And then quite often is that cancer policies and national cancer control plans and programs are not up to speed with this. And so there is really no, from a national level organization in terms of the resource allocation, but most importantly, even the guidance and guidelines on how to give cancer care within these countries or counties or systems. Then most importantly, the other aspect is cancer advocacy that is really quite missing. And of course research. So I'll start with some of I'll be mentioning some few things and looking at some of the solutions that have worked, even without COVID-19 bringing in a lot more complexities, but we shall also say, especially during this COVID-19 pandemic. So with infrastructure to support cancer care, we are looking at infrastructure for screening and early detection in most of the centers, infrastructure for pathology, especially diagnostics for patients becomes quite an issue. Imaging and staging, even when you've actually gotten somebody early, and then you do biopsy, then you find there are some challenges on being able to get some immunohistochemistry, especially the essential ones for you to make a good therapeutic plan. But in addition to that, for those who may potentially need radiotherapy, and I still understand, I don't know whether Jonas, it's still true, we do not have any radiotherapy unit or radiotherapy treatments in country as at the time late last year. And there is also, once you even have all these things, what about the treatment itself, the chemotherapy, the hormonal agents that are needed, the immuno-oncology drugs, the IOs, and some of these newer agents that are in the market, they're really pretty good in improving the quality of life and outcomes, both overall survival and progression-free in some of these patients. So looking at this is just going back and saying, in these systems, do we have any baseline survey on what is missing in infrastructure and human capacity gaps? And this one, I would actually use an example, for instance, in Rwanda, that was Kigali being a city cancer challenge. And also just from their own team, they have a lot of data in terms of what is needed, where they are, and how they move from that step to another step. And my hope is that, and Jonas, after presenting, we shall have more discussions on this, is that do we have concrete information on, yes, we do not have really cancer care, we have a few things that are missing, but what infrastructure do we have and what human capacity do we have? That would really be helpful. I know there is a very state-of-art anatomic pathology lab currently in Bujumbura, and so how much are we utilizing that to jumpstart the diagnostic process and improvement in diagnosis? And there is Professor Nagayo within the system, and I'm sure he's probably going to be on the call. We can discuss more around this, because these are some of the areas in which how do we actually support cancer care first before we even look at how do we improve that care now during this COVID period. There are several HIV infrastructures that have already been set up in several countries, Kenya included, and we go to some sites and we can leverage some of those HIV infrastructure, whether it is specimen delivery system that can help in delivery of some biopsies from rural or referral sites, whether it's the flow cytometry that is being used for HIV that can be leveraged for lymphoma, leukemia, diagnostic support. But there are various structures, including even community health workers that are moving as part of the HIV infrastructure, moving from house to house, whether it's discussing about HIV care prevention, maternal child health and all that, but also leveraging that to talk about cancer and where screening can be done and what can be done about those who are early detected. The other point would be MOUs and partnerships with neighboring countries. Right now, I know there is a center in Kigali with a radiation unit at Rwanda Military Hospital. And some of these MOUs with partnership countries would actually be very helpful to decrease the cost of some of the radiation. However, during this COVID-19, that still becomes a challenge because of the restrictions in movement between countries. And so some of those patients, we may have to discuss during this call what needs to be done. Then patient access programs with pharma have been very helpful in access to medications. There is this even 20 drugs bucket that was recently unveiled for several countries in sub-Saharan Africa last week, which is a collaboration between Pfizer, Novartis, and Mylan. But we also have each company having several access programs that can really improve the cost. And one thing I noticed is that even if you do diagnostics and you do proper staging, but you cannot really be able to treat these patients, then it becomes quite an issue, and still access is denied for these patients. The cancer infrastructure like chemotherapy preparation hoods, the good news is that quite a number of, there are some people who have been trained on cancer care within Burundi. And International Cancer Institute has actually assisted in training a few cancer registry people as well as oncology for general practitioners. But there is room for a lot more organizations coming in and assisting so that they can have in-country setup for cancer care. I think that is one of the most important priority areas. It's very hard to take care of cancer patients without a center that has been developed that you can be improving on. However, there's already a baseline center with essential toolkit for cancer care and supportive services. And obviously, supportive care and palliative care is very important with ensuring that there is essential medication working closely with some of the palliative care groups. Some of these are mentioned, just the human capacity and for cancer care is very, very important. And within this COVID-19 period, potential solutions would actually be the use of telemedicine and telehealth with some of the countries and counties. I mean, it's very hard for people to travel currently. And I think personally for us, we've actually been conducting several teleclinics where you sit in front of your computer and there are some patients being seen by other healthcare workers within various counties. And they consult you on either its management, but the history taking and the evaluation is actually being done on the ground. And this seems to really improve the quality. However, it always needs for some basic cancer support or basic cancer infrastructure to be available. For instance, if I say this patient should get adriamycin and cyclophosphamide, then you are presupposing that there is a pharmacist on the ground that can be able to mix this. There's a nurse that can be able to deliver this. There's a chemo preparation hood. So one of the things that we say, if there is no cancer care, how do we actually collaborate with various partners to have an essential basic system for care? So the level of training actually includes the whole multidisciplinary team that is needed for cancer care, and not forgetting social workers, patient navigators, cancer researchers, and all. There is also quite a number of countries in sub-Saharan Africa that are already plugged into telepathology. I know the American Society of Clinical Pathology with its CEO, Dan Milner, has been doing quite a lot of work within sub-Saharan Africa in establishing telepathology centers and assisting in quality in terms of pathology training. So this is actually an area in which, with that wonderful center, the wonderful equipment at Pathology Unit in Bujumbura, that you can plug into some of these telepathology centers, and usually has several other pathologists around the world. It's a virtual discussion, and you can discuss as many patients as possible. However, that also requires that a basic minimum of some of the pathological skills and immunos done, as well as having some basic equipment that can be able to scan the pathology slides. There's involvement of virtual trainings, and I think virtual trainings for us, especially with ICI, we've noticed this is one of the areas that this has picked up a lot. I would say that last year we were doing about 6 or so courses that we are doing at any given time. Right now we are doing about 7 or 8 classes or sessions per day on a daily basis, and we have more than 24 virtual trainings going on. I think during this COVID-19 has just shown that this is actually, as much as people say this is a very tough system to get accustomed to, but I think this will be the future most likely of a lot of our trainings. And we realize that even the trainings that require face-to-face, there's a huge component of that training that can be covered online virtually, and then you just invite a few people for the face-to-face skills training along the way. Of course, there are those courses that may require longer periods of time. And even recently, we've been looking at cancer registry, and also developed an online training program for introduction to cancer registry. But before, it was all face-to-face. So there are potentials for doing virtual trainings in terms of any of these gaps for health capacity building. And this includes tumor boards that can be done online, discussion of patients with various groups, but it involves the country itself being able to plug into some of the existing systems. This ECHO that we are doing virtually is actually one of those areas in which there's a lot that can be learned from it. And the people who are attending this ECHO, some of them can assist in actually plugging some of these gaps in capacity building from some of the work that they're already doing with other organizations or even in their own organizations. So there is a potential for that kind of partnership and utilizing some of the already available resources without necessarily doing extra investments in some of these things. One of the ways of the best way of human capacity building, I've always noted, is that starting in-country training programs. So if we are looking at Burundi, for instance, it would really be important to work very closely with some of the institutions of higher learning, the universities and the medical schools, to be able to see how easy can it be for establishment of some of the training, like oncology nursing, for instance, like training for histotechnicians, training for pathologists in country, training for oncologists even, or even working closely with other countries that have training programs to train the initial group that comes back to train the rest. This is also a very huge area, and during this COVID times, some of that training can actually be done virtually, as we've seen. There is nothing that can really progress in any country, especially in cancer care, without really everything being embedded at the cancer policy level, national level, where establishment of development of a national cancer control plan with a program that is a multi-stakeholder involvement, that has an operationalized plan, that this is what we want to do in the next 5 years with a strategy and various technical working groups. I think that from the whole thing, you can have small pieces of various organizations coming in and saying, we want to do cervical cancer, we want to do breast cancer, we want to help with colon, we want to help with liver cancer. However, having a nationalized, an organized national plan that sits within the Ministry of Health, because that is the driver of any of these programs, would actually really be a huge boost. And we've seen this in the programs even in Eswatini, where they established their own national cancer control program and had their own plan, and they're moving quite fast in some of the cancer care work in country because of that, because there is a little bit of coordination of the plans across the entire country. There's coordination of implementation and deliverables. You can quantify who is doing what and how it's done, and obviously you can actually synergize the activities of various strategic partners who are part of this. And it also gives the leadership prioritization of which projects seem to be more important, and looking at vertical programs that leverage what is already in existence to improve the care, as well as for more partnerships. Quality and standards of care would be very important. Right now, this is actually being affected left, right, center during this COVID-19. And as I think for those who attended a couple of months ago, we had an ECHO meeting where we talked a little bit about some cancer care and interruption during this COVID-19. And we've actually seen that interruption even in my own clinic. We have a lot of patients that have missed coming to clinic. There are patients whom we started on chemotherapy on, but you call them to get their second or third cycle. They say that, we are not so sure whether we'll come to the hospital and get COVID-19. And then there is also that fear that healthcare professionals also may actually be the people who are also spreading the COVID-19 because of our exposure to so many patients. Then we've actually also ended up having problems with the fact that if you're treating a patient and they get neutropenic fever, treatment of that neutropenic fever becomes such a big problem. So you have to actually have a plan and pre-plan. If you have a fever, what are we going to do about it? Because I even had a patient just a couple of days ago that had to be put in isolation. We had to wait for her COVID-19 results to come back before we actually did anything in terms of treatment and and the care for these patients. So if it's a patient that is in dire straits and really need care immediately, then urgent care, then unfortunately we may end up losing those patients. So there is a lot of information with the standards of care. I think we have a lot that we've lost in COVID-19, but there's a lot to gain. And part of what to gain is how do we establish even more virtual ways of contacting our patients. Like for instance, patients coming to the clinic that don't really necessarily need to come on a weekly basis or every 3 weeks. How can we assign some patient navigators to just call them and find out how they are doing? We've plugged in some centers to computers and told them that here is your Zoom link, will be available between this time and this time. And some of them are actually sharing cases, and our virtual team members continue every 2 times every week. I think some of these places, some of these things really, they do not substitute for the quality standard of care that is needed for these patients, but given the circumstances, some of these can actually help. So in a place where there is no cancer care infrastructure in country, Some of those things that we talked about in terms of having a national cancer control plan also goes down to deliverables like national cancer management protocols. The good news with these protocols in sub-Saharan Africa, we are awash with so many protocols. We have NCCN, we have ESMO, we have so many ASCO, and we also have the NCCN Africa or sub-Saharan Africa guidelines. I mean, there are so many to borrow from. However, every country has to decide what they can be able to do and how well to deliver it. Multidisciplinary tumor boards and multidisciplinary meetings still remain key to proper cancer care, regardless of whether it's COVID-19 or not. And so even when you're doing teleclinics, that it's important to have a multidisciplinary team that can be able to discuss every patient and see what is the potentially best way of providing care in this situation. And several organizations that I've listed, including NCI, ASCO, ESMO, could actually be perfect for partnerships with a country like Burundi in terms of assisting in improvement of quality, both education training and as well as care. And participation in regional meetings and data management system would be great. So we've actually been looking for various things because cancer is so wide and the needs are so huge and the teams that you need are so many people that it's imperative that we, especially in resource limited settings like low and middle income countries, that we have the hub and spoke models of clinical care. So you create one center of excellence at the university hospital, say for instance in Bujumbura, and then you have those other sites become your satellite sites that refer to this hospital or that coordinate with this hospital that is at the center, whether it's for pathology, whether it's for treatment and care and the drugs themselves. Nothing is really as more important. All these things I've said would not really be useful if we're not doing a lot of advocacy, and the role of cancer advocates in really improving care has been shown in so many settings, whether you are talking about Susan G. Komen advocacy in breast cancer, as many others around the world that really make the improvement and the quality of the care to really improve. But most importantly, tied to some form of research, even if it's implementation kind of research from the country itself. And I've written here some organizations, but we've noticed that even in our settings that they're working with foundations, pharma, NGOs, Ministry of Health, developing a good R&D strategic plan, both for the country, but also specifically for cancer, incorporating several stakeholders has really been very helpful in this. So as much as in other centers you are talking about, you already have a lot of clinicians, you already have cancer specialists, and now you are looking at how do you optimize the cancer care during COVID-19. In this setting, you'll be talking about if we do not really have those specialists and we do not have these services, how can we actually start building them even with COVID-19 in place? But most importantly for the others, like one of the questions was, there are already cancer patients who are being seen outside the country. There are some who are going routinely to get their annual checkups or every 6 months and so forth. Those are the patients that it's very easy to set up a teleclinic with various consultants or various oncology professionals from various countries. Now with virtual, it actually does not limit you to the number of people who can be part of this discussion, and therefore they can start giving some help. So for me, I'll be very interested during the discussion to know the specific areas of need and how can we prioritize moving forward, because those patients are already there and it's upon us to do something about them. I'm acknowledging all the patients and all this, so I'll hand this over back to Mishka.
Thank you very much, Chite. That was, of course, a fantastic, not only overview of all the key components of cancer control that are needed at the country level, but you also addressed the pandemic head on. And just to note that I unfortunately think we may have lost Dr. Jonas again due to the connectivity. So I think Benda is helping us trying to reconnect him. Benda, do you know if he's able to connect?
I'm trying to get him. I'll get back to you in a bit.
Thank you. And in the meantime, it does not go unnoticed that I really appreciate throughout your presentation, Chite, you made a point of noting the importance of partnerships. And it does not go unnoted that we are a very well-balanced group today of country level participants and partners. So I'm just gonna call out a few who are here, all of who have been mentioned by Chite, but we are represented by IAEA, the NCI, MD Anderson Cancer Center, the NCCN, the Bush Institute, the International Cancer Control Partnership, which I will make a big shout out for in terms of supporting countries in national cancer control plan development and implementation. Partners in Health, NYU, UICC, just to name a few. There might be other partners out here. So calling on all of you to participate very strongly in the discussion, and also welcome folks to use the chat as an opportunity to share activities that you are doing in the region, as well as ways that folks can be supportive, and also for our country level participants to be able to share introductions as well via the chat. We did have a comment from Dr. Francois in Rwanda saying that I think this COVID-19 pandemic is a wake-up call to governments to strengthen local health systems with a goal to provide needed care in country, which is a very good comment and follow-up to Chite's presentation. And Benda's follow-up to that is, I absolutely agree with you, Francois. Coupled with this should be the call for cancer prevention and access to screening and early detection. So very good points. So if we have not had Jonas join yet.
He's back on the line. I'm logged in as myself.
Oh, wow, this is interesting. Okay,
yeah, so
welcome, Jonas.
Thank you very much. I'm here. Sorry, I was somehow late. I tried to connect myself, I couldn't, but Francois and Benda sent me a link.
Oh, so fantastic. Great.
Yes.
Oh, welcome. Now, great. I'm not sure how much of Chite's presentation you were able to hear.
I look big. I think I like 75%. I got.
Oh, fantastic. Excellent. All right. So before we start the discussion, I will turn this over to you, and our colleague Christine at Chemco is going to run your slides for you. Unless, are you able to run your slides yourself?
I don't think I will be able, because I don't know how to do it on Zoom. Yes. But I have the slides with me here. And let me see if I can do it.
And as you're getting ready, Dr. Francois wants to know if you're in a plane, but I do believe that's just your photo. Please tell me you're not actually in a plane. Okay.
Okay. Is this like?
Yes, perfect.
My slides?
Yes,
okay,
we can see your slides. Okay, over to you.
Okay. Okay, first of all, I have to do Jonas from Burundi, a country which is between East and the Central Africa. Rwanda is our neighbor, and the Congo, Tanzania, and also Zambia through Lake Tanganyika. For the population, it's a country of 12 million, population of 12 million. I mean, men and the female are almost the same, because they are around 6 million. For a little bit about the data on cancer, I have to tell you that we started the cancer registry early last year, but we haven't.
Sorry, Jonas, I'm just going to interrupt you briefly. Are you able to put it into slideshow mode? There's a button up top.
Oh.
Sorry. Thank you, Dr. Francois, for pointing that out. There, perfect. Yep.
Okay. So as you can see, this was a situation given by Globocan, according to the neighboring countries. As you can see, the cancer of the cervix, I don't know what is written here. The cancer of the cervix was the first with 1,859. So taking 89%, sorry. Oh, okay. And for in males, the cancer of the prostate is the leading one with 754. You can see the second one is Kaposi sarcoma, esophagus, the third, the liver, and the colorectal is this. But I think for us, these answers are not reflecting the reality, because in Burundi, I think the prostate may be the first in men, but the liver might be the second, because people are having many numbers in hospitals of liver of the cancer, and even the stomach. So this is maybe it's because of the estimation of Globocan, according to other countries who are neighboring Burundi. For the female, as I've said, the cancer of the cervix is still the first. The second is the breast, and the colorectum and esophagus. Here I have not much to say on it because I think this might be the right one, but we haven't got the real data from Burundi. As a matter of the situation, Burundi with COVID-19, the situation has become very worse. Though it was like this even before, because in Burundi we are not doing any treatment on cancer. We are not doing chemotherapy. The only thing I've been able to do last year, we got a national in a teaching referral university, a pathology lab given by World Bank through EXA Health Community. Now we are having a problem of oncologists. We don't have anyone who did in oncology. The one we had is studying in China, and now I think has not yet finished. For about the cancer situation, it's not easy because the people used to go out of Burundi for getting treatment, India, Rwanda, Kenya, and thank you, Chite, very much because he used it to receive our patients and they treat them for free. This is what I can say. But now people are not being, those who were used to go to India, they can't go, they can't fly. Those who are used to go to Rwanda, there is lockdown, they're not going. For example, today I was trying to help someone who's having a cancer of the stomach. He wants to do treatment in the Ocean Road Cancer Institute in Tanzania. So I'm trying to get all necessary documents, but he will be obliged to travel by car for a journey of 2 days or 3 days. Someone who is sick, it's very hard for the person, but he has no choice. He has nothing to do. So with COVID-19 situation has worsened in Burundi than ever before. Patients used to get treatment from abroad. As I've said, they actually left hopeless without any means of treatment. The other problem they're having is how to get medicines, to get chemo. They used to get chemo through patients who are going to India will be back with chemo of themselves and for others. They will say, please bring me chemo like this. But now it's hard. The FedEx or the transfer through air is not that cheap. The medicine will reach here already expensive. So many of them are not able to purchase it. I've tried to do an online consultation, but many of them, because it's not something which is very used in Burundi, they don't trust in it. When we do, they are used to sit beside a doctor, talk to him, do a physical examination, and that is when they feel like they have been treated. So I'm trying to convince them, convince the associations, the NGOs who are working with these people, to see if they can start to understand if we can manage to do an online consultation so that we may see how to do treatment for these patients. For maybe, for what to do, first of all, for the time being, online consultation, I've said, with an oncologist is the main solution because we don't have someone here to consult them. And me, myself, I do use the lead I got from ICI because I was training. I did the fellowship for oncology for general practitioners at ICI. That is what I do try to do with them, but it's not that much without someone to do a coaching with me. The second is to provide drugs for chemotherapy to as many patients as possible, because it's already, imagine, many of them, they are here, they know they have cancer, but they are not getting drugs. Because now we have an pathology lab. They do diagnosis, they get a positive, but they don't know how to procure. Because when we try to buy the medicine, it's very expensive. We need a collaboration. We need something like to work like AIDS did, because AIDS, the medicine was very expensive, but there was something like an aid so that people were treated without paying money. I think that is what we need in Burundi, because people as you know, it's a low-income country. People are very poor. They can't afford the medicine of which is being bought around the $200, $100, $300, $500. It's not that much easy. For the future, for the near future, the training for a small team of medical officers, nurses, pharmacists, and the laboratory assistant in order to start administrating chemotherapy in Burundi is very important. This is what something we have discussed with ICI, with Chite, but what we are waiting for is a memorandum to do with ICI to see if we can take a small team to Eldoret with pharmacists, laboratory, from someone from laboratory and nurses to train a small group of people who can come here and start a unit of chemotherapy here in Burundi. We see what is the best, if to send them there or if to bring teachers, no, to bring the trainers from Eldoret here. We have also contacted the Ocean Road Cancer Institute. We are also trying to see how we can work with them, but it's not that easy due to COVID. We can't travel, can't let our team go there, and they can't come here. So it's now very difficult. I don't know even what to do. And I don't see even if the COVID is over, how we'll do it, because something which needs a memo and an engagement from the government of Burundi and any other NGO or any other government to see how to do it. And find also a specialty oncology fellowship training program to Burundian medical doctor. This is very important because we are not having anyone as a doctor in oncology. We don't have oncologists who are here in Burundi. Even those Burundian who did oncology, they are not here. They are in other countries. So if there can be how to get a training for specialty, this will help much the country. We need to train people who are committed to the population, who are committed to the country, who sit down and start treating people. That is what I think will be very important. Thank you very much. I think my presentation was not that much longer. Thank you.
Thank you so much, Dr. Jonas. And that was really fantastic. A lot to take in, a lot to consider here. And I want to start by actually apologizing. I forgot to do your introduction beforehand, so I'm going to do a post-introduction. So for those of you who don't know Dr. Jonas, he's the head of oncology of the oncology department and the cancer focal person and supervisor of the Bujumbura population-based cancer registry and NCD's unit at the Ministry of Health in Burundi, just so you know exactly where he's stationed. And he's for more than a year been heading the department. Prior to that, he actually was the director of the Kirundo Hospital for 3 years, and he was responsible for administration, management of the hospital. He's an MD, he holds a diploma of master's in public health and a diploma of medicine. So has had very good experience both on the ground and at the policy and ministry level. So thank you again, Dr. Jonas. Now we're entering our period for discussion. We've had some activity in the chat. I want to encourage you to unmute and jump in with questions and comments and guidance and suggestions. But I'm just going to read just a few of these comments from the chat here first. Several around the use of telehealth and online services. So Dr. Amaka saying that one of the benefits of the COVID-19 pandemic is the huge adoption of teleconferencing. The potentials are huge for building capacity within the continent, and agrees with Chite on exploring this, as does Dr. Francois agree. Dr. Emmanuel from Uganda says embracing virtual platforms is definitely a needed step in the COVID-19 era and beyond. It's delivering easier and cheaper and more appropriately with limited movements and limited resources. Benda's also sort of giving a plug for the ICI virtual tumor board. It's a very efficient way of reaching others in the continent. And Dr. Manuel followed up to say there's a need to have more advanced cancer centers to virtually twin or link up with less resourced ones, which was also mentioned by Dr. Jonas in his presentation, to exchange ideas and also in management of patients. And there's several others here. Dr. Mary Nyangasi from the Ministry of Health in Kenya, what COVID-19 is teaching us is the importance of making deliberate investments in cancer health systems. Yes, that is key. And then, Dr. Francois calling out Lori. I've seen Lori from Partners in Health here. She can talk more about providing chemo in centers with no oncologists, which can be informative. From Burundi, twinning with known centers can help the local team. So Lori, I might ask you to speak to that briefly. And there are additional comments here that are coming through. So instead of reading additional ones, I'd like to open up here for Prof. Chite to respond to Jonas and others to share. And Lori, I see you've unmuted, so if you want to go ahead and lead off, please do.
Sure, thank you. Thanks, Francois, for inviting me to speak around the work that we have done in Rwanda. So I actually, along with several other colleagues that are on the call, Dio and Sarah Slater, work at the Dana-Farber Cancer Institute in Boston. But we have developed a relationship with Partners in Health based in Boston and working in about 12 countries across the world, and have tried since 2012 at the invitation of the Ministry of Health, accompanied general practitioners and internists and nurses who were not trained in oncology to run training programs in person and remotely. We make many, many in-person visits throughout the year where our medical oncologists and radiation oncologists spend several weeks in the country. We have had an expert nurse in country for most of the years that we have worked with PIH in Rwanda at the Butaro Cancer Center, and have developed an orientation that involves both classroom training and hands-on training for nurses to learn how to mix and administer chemotherapy. We have also worked with 2 senior nurses for them to become the oncology educators there so that they can train new nurses as they come to work in the unit. Along with Dan Milner, when he was back at the Brigham and Women's Hospital and now part of the American Society for Clinical Pathologists, helped build a pathology lab that started out before they had a pathologist with path techs and sending samples to Boston, and then telepathology. And now we're fortunate enough to have fabulous pathologists in country, mostly thanks to Dan Milner. We hold weekly tumor boards where our physician and nursing consultants are on the call with our colleagues in Rwanda, and we review all patients that they need some guidance and assistance with. We also, probably one of the most important things that we did, and I don't think I appreciated it at the time, and in retrospect it was one of the most important aspects of the program, is we collaboratively developed treatment protocols for treatments that we had drugs and expertise to treat. And following those protocols really has enabled internists and general practitioners guidance on how to treat breast cancer and how to treat Hodgkin's disease and non-Hodgkin's lymphoma and Wilms tumor and ALL. And so that really has been, I would say, the backbone of our program. But that also requires updating those protocols as new drugs become available, or in our case, when radiation became available in the country. So anyway, I think I'll stop there and see if my colleague Dio Fidelu has anything to add, or if there are any questions.
I think I would just wait for questions.
Thank you, Lauren. Thank you, Deo. Jonas, hearing from them, is there anything that strikes you as something that could be pursued or looked at as a model?
Yeah. For me, I think this, what is important now is what they're saying. It's how we can train people, how we can at least start doing this treatment in Burundi, because this cancer is for everyone, for poor and the rich person. The rich guys, they can afford a plane, they can be transported to any other country. But for this, I'm suffering when I see children dying hopelessly, women dying hopelessly in the village due to cancer, cancer of the cervix, cancer of the breasts. It's very, very, very sad, very sad. Today I was visiting some patients in teaching referral university. They are doing nothing. They're just receiving this local treatment for the wounds, but we are not doing anything about chemotherapy. We're not doing anything about radiotherapy. People are sitting there waiting for them to die. And I'm this much concerned because even my dad died out of cancer of the kidney. Yes, he had the diabetes and the hypertension. It's complicated up to cancer of the kidney. And even I have a relative in my family who died out of the cancer of the cervix. So every family here in Burundi has lost at least someone due to cancer. So it's not that easy. If I can manage how to get a small team trained, start at least giving chemo, and they find a way to get chemo in Burundi, which can be cheap to the patient, which is affordable. This can help very much. And they try to grow up slowly, but at least they start the basic of the treatment in the country. Yes.
I think,
Very intense.
yeah, that's it is an incredibly tough situation, and I think Francois can sort of speak to this in Rwanda, the sense that you know, it is hard for one person. You as one person, it's a really hard burden for you to shoulder. So I think certainly the idea of having a team, I think the idea of having you know, a central place within the Ministry of Health that is able to coordinate a variety of partners, because it's not, unfortunately, it's not a burden that just one clinician can handle. I think it's something that does require the support of a structure within the Ministry of Health. So yeah, so it is a tough situation.
Indeed. Anna, I saw that you had
Yes.
also wanted to say something.
No, I agree entirely with the previous speakers. And I was just thinking, looking at, he actually indicated that, you know, some of the doctors who have been trained, they didn't come back. So going forward, having some localized training facilities of multidisciplinary team members will actually help retain the local expertise, because when you send someone outside, it's not that they may not want to come back, but when they come back, they're going to be overwhelmed. And maybe they're trained with so much technology in a different environment, they will not cope when they come back. Yeah. Whereas if they're trained locally, and they will be facing the local challenges and taken through the local challenges, they are more likely to stay than those who train outside.
Yeah.
Thank you. That's a very good point, Anna.
Misha,
I just want to, sorry.
I had a quick one.
Go ahead.
I just wanted to really just follow on what Anna has said, like just to emphasize on it. It's actually very, very true. And in Kenya, it's not until we started the in-country trainings, whether it's gynecologic oncology training that we were doing through Ampath in Eldoret, or the oncology nursings and all that, that you can actually see. And even now, there's medical oncology fellowship training at University of Nairobi. And that has really considerably increased the number of cancer, you know, the capacity building within cancer, and they can stay within and improve the outcomes. So I totally really agree that even as Jonas, you're thinking about Burundi, and even if there's no cancer program, how can you work with all these partners who are on this call? Honestly, the number of people on this call and what they represent is enough to make Burundi be a center of excellence in cancer care. So I think we could actually put our hands together and say, who is interested in education and training components for Burundi, who is interested in cancer trainings and protocols development and standards of care, who is interested in pathology and its services around it, cancer registry, who is interested in data and how we can actually collect that for research. So I think within this group, my thought is that the best would be, how can we have some people even volunteering some of these things, even virtually, to work with Jonas on this. And Jonas, as you know, ICI is always ready to support what you are doing. Thank you so much.
Yeah, no, that's a fantastic reminder. And as I was mentioning earlier, the existence of several partners on the call. Yes, Jonas.
Okay, first of all, I thank very much the ICI. Thank you, Chite, because you have been there for Burundi. Chite has trained us for oncology for general practitioner. I recently did the methodology to research cancer of the breast. So he's helping us. But the problem, these guys, some of us, they don't see the interest of learning on the internet. I think what is the best is to get a team be trained here. Because they are already doctors, they are already medical doctors. What they need is a training to keep up, to try to bring something on. About the fellowship, I've tried to connect even myself to this oncology fellowship in Uganda. But their conditions are not meeting with Burundian conditions, because they are taking those people who have masters. But for us, our medicine is 7 years. 7 years. When you finish, you are a medical doctor. In Burundi, we are doing a Belgium system, because when you finish, you go directly for the specialty. So it's taking a long time to explain them if they can start receiving our people and let them do that fellowship, because we need people who did the pediatric oncology, gyne oncology, and even adult oncology. At least, as they have said, it's not a matter of someone, it's a matter of a multidisciplinary team. And as you can see, the government is trying to do its best, because it has put it in place the oncology department. They are trying to put this and this, but they are facing many challenges. There is COVID, there is malaria, AIDS at least is getting down, but we have other diseases which is imbalancing the decision makers. That is why we need the partnership with universities, with I don't know, NGOs, everyone who can do something for the country. Because even we are in 2020, but someone is crying for treatment and they can't pay. A parent is calling me, because everyone knows me in Burundi. When they have cancer, they know there is some, because I used to send my patients to ICI, and ICI used to treat them for free. That was very good. But with COVID, it's not easy. And not everyone was able to go there, because they have to get their own airplane fare, ticket. But they have come to know me. They do call me a parent with a kid of 3 years who's dying, saying, how can you help? I have children. I do get, I'm always affected day after day just because of this situation. Hope one day.
Thank you, Jonas. I just want to make a note real quick. Usually our sessions are 1 hour long, and this one is an extended 90-minute session to allow for additional discussion. I understand if those of you may need to hop off, but just put a little note in the chat if you are saying goodbye. Also want to just comment that Kirsten Hopkins from IAEA had noted that Ocean Roads Cancer Institute were keen to help, and they've achieved a great unit, having seen what worked and what didn't. She does say it's hard just now, but hope that these plans will go ahead. And she also says, so Jonas, please make note of this. Please keep using the IAEA technical cooperation mechanism when you can. All good wishes from us. We want to help. So that is a pledge for support and from IAEA. So I think Chite, you raised your hand. You had a question or comment?
No, it was just a quick one to say that having been to Burundi and gone around and met some of the advocacy groups, and even in their hospital did a ward round with them, there is a lot of eagerness to learn and eagerness to actually set up cancer centers. So any teams that would be interested to assist Jonas would really be very welcome. And Jonas, my hope is that you could get a list of few people, including the Ocean Road Cancer Institute that has shown interest, and various others. And you can even organize some, maybe even monthly conference calls where we can just come in and see how do we build on to what you are starting. And as we said, cancer care has to be very organized in terms of its delivery. And considering that it has a multidisciplinary approach, as you've also said, it's important that we can help train as many people across the multidisciplinary nature as possible. So this is really a true area for true partnerships. That's all I wanted to say.
Thank you, Chite. That's a really great suggestion. And Jonas, please feel free to follow up with myself or others on this in this network if having some type of a monthly meeting might be helpful, as Deo recommended. Having that sort of central team that's run through the Ministry of Health can really be a great way to get that discussion going. I know Louis Foxall at MD Anderson had the question around that. When you have several areas of cancer care that need development, is there any strategy about where to start or how to prioritize? So convening a group may be helpful. I know Mary Nyangasi from Kenya leads the National Cancer Control Program there and has a multi-stakeholder technical working group system. So definitely please consider that. Dr. Francois, you have your hand up.
Okay, so thank you so much, Mishka. It's a pleasure to see again to hear again my friend Jonas. So, I mean, yeah, I hope you are doing well in Bujumbura. So yes, what I would say, yeah, I think partnership is key, just especially in our countries where we're still struggling to put in place, like working cancer prevention and control programs. So, we have been very lucky in Rwanda to have partners in health that really are very committed, that are, of course, responding to local needs, to government needs. But again, maybe what I can tell to Jonas, it's better when you have those partners, you should have really plans in place. You should have the government with. There should be a plan. So because sometimes, of course, yes, we are calling partners in efforts in Shutimu Buzima. Just it's like a friend forever. But of course, with situations like this one, like COVID, like some financial crisis, sometimes those organizations that are also getting money from those philanthropists, from those donors. So it's better you have really a plan. How the government can also chip in, how the government can be fully on board, so that you can work together for those partners. Otherwise, everything should not be on the partner's shoulders. So you should see how working together, how can you make that partnership, but also make sure that really the government is also financing, is also putting much resources, efforts, so that at least at the end, maybe once that partnership is over, maybe you can really continue from where you are and continue providing really good cancer and prevention and the treatment services. So I think for Rwanda, of course, it's really good that with those partnerships, you can show that it's possible. You can show that really even to those policymakers that cancer is not a death sentence. When people are diagnosed early, they can be treated and go back to work. And especially in our countries where cancer is affecting really those young women, young men. So you see, especially if I can talk about breast, so it's affecting those women in their prime age. So meaning that if they can be diagnosed early, treated early, it can really help you to make a case. So for Rwanda, yes, we are not yet there, but I think we're on track. We are just, of course, working closely with many partners in AF and also other few partners that we do have. Now the government is investing really more in cancer care and treatment. So making sure that really the burden is not only on the partner, but also the government is also putting in something. And we think that can lead to sustainability. So that's what I wanted just to share here. Thank you.
Thank you, Dr. Francois. And I think that that's one of the benefits of this community is that there is the opportunity to liaise with countries that are all across the spectrum in terms of cancer control planning and cancer control prevention and control. So I appreciate that comment and the partnership I'm already seeing happening. I'm going to go to David next because he has his hand raised, but before I do that, I've noted, Chite, that you have to leave at 15 minutes past the hour. So let's wrap up in the next 5 or 10 minutes so that we can have a couple of closing remarks from both Jonas and Chite. But over to you, David, real quick for what your comment is or question.
Thank you very much. That are very insightful conversations from the two speakers and all the sharings that have happened. I just want to make a comment about the role of regional economic blocks. In the long term and in terms of sustainability and political ownership. It's great to have partnerships, obviously, between institutions, between professionals, but for purposes of maybe institutionalizing and sustaining some of the initiatives that are huge and countrywide, I'm just thinking that perhaps one would also want to explore the regional blocks. For example, the East African Community. I think the West Africa, they have ECOWAS. There's also the South, the SADC in the South. I can see someone from Zimbabwe, and some of those countries are part of SADC. I think Tanzania is also part of SADC. So I think some of these regional blocks do have specific units dealing with non-communicable diseases, including cancer. At least I know the East African Community based in Arusha does have, and I know Burundi is a member of the East African Community, but how much and to what extent we should be able to advocate for acceleration of cooperation between countries, or country to country cooperation, so that some of the support, for example, from a Ministry of Health in Kenya or Ministry of Health in Tanzania and working the Ministry of Health in Burundi, how can we leverage on that? I mean, the regional blocks have many priorities. And I think the speaker from Burundi did mention about a donation from one of those. And I know even during this COVID crisis, the East African Community did donate, mobile labs to the member countries, mobile COVID testing labs for border points. So maybe these are things that we could also look at. If we are doing that, it is still within the public healthcare space. But what can we do to make sure that cancer is part of the agenda? I know that they do have a lot of nice words on the websites about non-communicable diseases, but translating that to action. For example, how can the sister countries around East Africa help Burundi, at country level, at government to government level? So maybe something I'm just throwing out there. I don't have a solution, and I'm not particularly well connected high up in the regional blocks, but I think it's something we should start thinking about. I know we have an East African NCD Alliance, which is an advocacy group, and they have done a couple of presentations to the East African community, not just about cancer, but about many other things. But I think we should be able to tailor something around cancer, show the opportunities that exist, for example, with the international cancer training in Eldoret, and how can governments now support that so that it doesn't fizzle out when the funds run out. Thank you.
Thank you very much, David. And Benda, I see you have your hand raised, but before you comment, just real quick. So Amaka also makes a very good comment about aortic could be helpful in training in Burundi, and has asked if you can reach out to the vice president for your region. And I believe, who's the East Africa? Is it Miriam Mutebi from Kenya is the East Africa aortic vice president. Benda is nodding in agreement. So Jonas, if you don't know Miriam, we can connect you to her. So Benda, last comment from you, and then I'm going to turn it back to Jonas and Chite to close us out.
Okay, so thank you so much, Mishka, and to the two presenters. That was really, really insightful. It just occurred to me that in Professor Chite's presentation, there was mention of the other cadre of healthcare workers, or if you so call it, advocates and patient navigators, that has not come up in this conversation at all. And I'm thinking for us to have a sort of more concerted effort towards helping the situation in Burundi, we also need critical voices and critical masses at the community level. Now, we recognize that Burundi has recently gotten new leadership, and this is the moment where they're setting priorities probably of what the country is going to look like going forward. And this is the time also to raise critical voices of either patient advocates or patient advocacy groups that can start bringing the voice across that there is a need for this cancer care and control in the country. Because as Jonas is speaking policy and speaking at the clinician level, there also needs to be demonstrated need at the community level, so that then when politicians are making decisions, when government is making decisions, they're also thinking of their constituents. I think it's something that we would also want to explore to see how we can work together to build a critical voice in advocacy in Africa. Thank you.
Thank you, Benda. Very good point. So a lot has been covered, and I appreciate everybody staying on these extra minutes. I actually think this is really helpful because we tend to run out of time right at the top of the hour. So first, Jonas, to you, if there's anything that you've taken away from this that you find has been helpful or additional questions you have, and then Chite to you to close.
Okay, thank you very much for this chance. First of all, I'm very happy that at least there are people who now know the situation around, except Chite, because Chite has been like my father now. It's like my father, because whenever I have problem, I'm sending him a message, I'm calling him, and they're saying, Jonas, do this and do this and do this. But he's also overwhelmed. He's carrying a whole country on his body. I don't know how to say it. But what I have to say is this: I have a hope that through this meeting, at least I will find people who can train my people here in Burundi. And these fellowships are being done around East Africa, Uganda, Tanzania, Kenya. Please, if there is a way to let us be trained, we'll be very happy to train our people there and take them back. Because taking someone in Europe, America, Canada, they will never come back. When they get there, they get a good life. They say there is no need of going back to Burundi. So I think these neighboring countries, they already have good systems which are well organized. We can be trained there, and they also have their team coming here to train nurses, pharmacists, and at least that's something. I really want to see at least one day chemo being administered in Burundi by a Burundian trained in Burundi. Thank you. That is my dream.
Thank you, Jonas. Chite, any last comments? The father of cancer control in Burundi, apparently.
Not really. I'm actually humbled by that. So I would say that, first of all, thank you, Mishka and the entire team for this kind of discussions. As you noticed, there was really no platform for this kind of wonderful discussions that can actually really bring some very long-lasting impact. That's one. And then working with Burundi has been so easy because of someone like Jonas, because you actually really need somebody that is so driven. And Jonas not only acts as a doctor that sees patients, but also as an advocate for care. Even the time when I went to round there and left and got a few patients to come to Eldoret for treatment, it was because of his passion, because we didn't even have funds for these patients, but we just said we really have to look for ways of improving this. And as most speakers have said, it's not sustainable that way. However, how do we create something that is very sustainable and it's done by Burundians in Burundi, and they can continue training others as well? So my request would be, first, people who are within this community that can assist in any of those areas that have been mentioned, please forward your names to Jonas and let's start engaging. Second is that the training programs, whether it's at Ocean Road or University of Nairobi or other centers that are training fellows, can you please relax on your admission criteria for some countries that do not really have necessarily a system of training that is comparable to other systems. Like if you have a team, a doctor that has graduated from Burundi that is interested in becoming an oncologist, then you could actually take them in and train them so that they can go back and set up practice. And as we've said, the only way of really improving quality cancer care is in-country training and in-country care that is really done by the teams. Then lastly, what has been mentioned by Benda is very, very important, the issue of advocacy. I'm always going back to the point that the advocates are actually the ones that do most of the work that ensure things really move. Whether the things move from a policy standpoint, they move from access standpoint, it's usually like very strong advocacy groups, because we as doctors in the clinic, most of the time, as much as we do some advocacy, you are busy seeing the next patient and the next patient and the next patient, that you are really not having the time to really go to these meetings where a lot of decisions are being done that affect the entire country. So our hope is also, how can we look for and strengthen the groups that are in country in Burundi, advocacy groups, and connect them to the other advocates within the region, so that as Jonas and his team are working from the end of the ministry, you also have advocacy groups working from a huge group of advocacy groups around the world that can bring cancer care to Burundi. And I'm hoping, Jonas, that this year does not end before you start giving chemo in country and doing your biopsies and reading in country. Thank you so much.
Thank you. That was fantastic and a great way to wrap up. I appreciate everybody's time today, Jonas and Chite, for your presentations and for this very informative discussion across. Jonas, this is not going to be the end that you hear from us. I will actually follow up with some of the notes that I was taking today, let's look to see about how we can make this a joint partnership to support Burundi and support other countries in the region as you move forward. So thank you all for your time. I will be sharing the recording afterwards. Don't forget to fill out the survey. I've put the link in the chat. Our next session is July 23rd. We are still looking for a case presenter. The topic is on cancer surveillance and the impact of the pandemic on the surveillance, on cancer surveillance and cancer registry implementation. And Courier from Kemry will be the didactic, but we're looking for a case presenter to go alongside with her. And as I said at the top of the hour, the August 6th session is wide open. The topic of which is how countries are strategizing for reopening cancer care services amidst the ongoing pandemic. So welcome any suggestions there. With that, I will close out. Thank you very much and enjoy the rest of your Thursday and the rest of this week. Take care, everybody.
Thank you all and goodbye.
Bye.
Thank you.
Oh,
bye.
Kirsten, there you are. Bye.
Hi, I'm here.
Hello and goodbye.
Oh, with the COVID hair, you know.
Oh, it looks lovely. All right, bye.